which is going to be on psychiatry. I feel with psych there's a bit of a shift in focus. Basically, I think a lot of the questions really focus on what's kind of the diagnosis and kind of trying to get between the subtleties of different similar presentations, or about the management and its kind of short and long-term consequences, particularly when it comes to drug side effects. So there's not that many conditions to know about, but I do think you need to know the big ones in a lot of detail, particularly the big three of depression, bipolar, and schizophrenia. And again, it's something that's really important, the different stages of management and their monitoring and complication of drugs as well. So there's the old adage that medicine is like learning a new language. I think that this holds the most true for psychiatry. So what I thought I'd do is go through some of the terms that get used a lot, just so we're kind of crystal clear in our mind what we're talking about, and so you guys have a reference. And because I think they get used a lot and no one sometimes really stops and explains them. So some of the stuff that I've kind of put in these first couple of slides will be referenced later. And I won't go through all of them, only ones I think are particularly important or relevant. So obsessions and so compulsions and obsessions I'll go through properly when we talk about OCD. So delusions is just basically a fixed belief that's unswayable even in the face of overwhelming kind of conflicting evidence. And it's not really exclusive to mental illness. I'm sure we know a lot of people, I think, who have certain delusions. But delusions of reference is something that's very different. So this is when people think ordinary, inconspicuous things are related to them and somehow have a special significance in their life. So what I want to do is give an example of this. So let's say there's a news broadcast. So someone who has delusions of reference will think the news broadcast is somehow talking about them specifically. So let's say the newscaster is saying, like, okay, we're going to have 20 degrees Celsius and it's going to be sunny. Someone with a delusion of reference will be, oh, they said it's going to be sunny, therefore this is when my neighbors are going to attack me. They'll think that something that's completely ordinary has some special significance to this somehow. If we contrast this with a hallucination, so hallucinations they differ from delusional perceptions. Hallucinations they get a different sense. So they would hallucinate that the newscaster is saying something that they're actually not. Whereas an idea or delusions of reference, they'd have correctly sensed what they're saying. They've correctly heard what the newscaster is saying, that it's going to be 20 degrees, but they've somehow thought, okay, this has a special significance to my destiny. Whereas in hallucination, they'll actually see and hear the newscaster saying your neighbors are going to attack you or something like that. It's something I can go through a bit later if you want, but it's the key thing between kind of delusions of reference and hallucinations. Or in delusions of reference, they are correctly sensing what's going on, and they just think it somehow has this special significance to them. Whereas in a hallucination, their actual visual and auditory input are different to what's going on. So an example I had actually in practice was someone who saw a red bike going past, and they thought this means I have to go to the Buddhist temple. And then they saw a traffic light turning orange, and this was the Buddha telling him he's special. So we've kind of touched on hallucinations, how it's someone sensing or perceiving something that isn't there, and they can't really control or direct these. Then overvalued ideas are basically delusions light. They're kind of false and exaggerated beliefs, often that they kind of find preoccupies their life, but they can actually be persuaded out of them, whereas someone with delusion is absolutely rigid in that. So an example would be kind of losing weight and body image in anorexia or body dysmorphia. So I feel like their perceived body image is an overvalued idea. They'll care about it a lot more than anyone else would, and they have a different idea to what everyone else sees, but they actually can be persuaded out of it. And a slightly different term that I actually got confused myself was monomania. And that's where someone's kind of obsessed with a certain topic and they'll only speak about that and they'll keep on circling back to it. So I wanted to go through quickly what psychosis just actually means. So just in basic terms, it means someone losing touch with reality. And by that, they'll experience either psychotic symptoms, which are either delusions or hallucinations. And that's basically stuff that is what they call it qualitatively different from the world. So that's basically stuff where they're seeing or thinking about the world in a completely, totally different way from someone else who is not psychotic. So another term I wanted to clear up was thought disorder, since it goes thrown around a lot, but no one really explains it. So when people are talking about thought disorder, they're actually mainly talking about formal thought disorder. So your thought, as you might know from your mental state exam, gets split into content and form. So content is just kind of delusion, stuff like that, what they're actually thinking. Whereas formal thought disorder or thought disorder is a problem with thought form. So it's disruption with the process of how kind of thoughts flow together logically from one to another. To become a formal thought disorder, this is then evidence in someone's speech. Basically, you can see they're thinking in a disorganized way from the way that they're speaking. So there are kind of a few examples of this that I've listed, and I'll kind of explain the ones I think need clarifying. So you have circumstantiality, where they'll kind of talk a lot of unnecessary details around the topic, but they'll kind of circle back to the original topic eventually. Whereas tangentiality is when they'll just never return. They'll just go off on a tangent and you're not getting them back to the original question. So then in the middle, I kind of have the ones that are around basically loosening of association between ideas. It's like derailment and night's move are pretty similar. This is where the kind of links between ideas are lost. I mean, they'll go between one unrelated topic to another, and night's move is kind of a more severe thing when there's absolutely no connection between the topics they're speaking about. They've got clang association, just a form of loosening of associations where they go between ideas based on kind of the sound of the words or the rhymes or stuff like that. And then you have ones to do with speed, like pressured speech, just rapid, frenetic speech. And then flight of ideas is the underlying thought disorder, which just kind of shows their thoughts are racing and they're going between lots of ideas very quickly. So on to our first SBA. I hope the poll is all up and working now. So the important thing here is that it's the first presentation in someone with no history of psychiatric disorder. So this means there's quite a wide list of differentials for their psychotic presentation. It could be caused by infection, brain injury, Wilson's, drug-induced, and therefore these people where it's the first presentation and they have no history, you need to do a full medical workup to rule out any medical causes of their presentation. So if someone is starting to have symptoms, you're worried about the kind of psychosis or schizophrenia, then what you can do is you can refer them to the early intervention service, where they'll kind of go through these psychotherapies like CBT or family therapy. What you wouldn't do is you wouldn't try and give them oral antipsychotics to prevent them turning psychotic. And then if they do, so if someone does present to kind of A&E or anything like that with their first presentation of psychosis, what you should do is do a full kind of assessment, full list of investigations looking for any of your differentials. And then if it's found, you rule out kind of any organic causes, then you'd start them on a atypical antipsychotic and probably also a psychological intervention as well, something like family therapy. So schizophrenia was the biggest and most important area of psych. In simple terms, the heart of the condition is the loss of the ability to differentiate what's real or not. And this is probably the one time I'd say in medicine it's important to know the risk factors and epidemiology of it. So I've listed that on the bottom left there. So with schizophrenia, you have positive symptoms and negative symptoms. So the positive symptoms are just thinking or behavior that people did not have before they had schizophrenia or were ill. So it's stuff that's kind of added to their psyche and behavior. So that's stuff like the delusions, hallucinations, thought disorder, everything like that. People only having positive symptoms and no negative symptoms is actually better for their prognosis. So then you have the negative symptoms. So this is just thoughts, emotions, or behaviors that people used to have before they were ill, but now they don't. So this is stuff like your apathy, your blunting of affect, or your social isolation, any depressed mood. It's just kind of stuff that they used to have, emotions really, that they don't anymore. And they're associated with worse prognosis. So again, going for your first rank symptoms, auditory hallucinations, the classic. It's usually them being talked about in the third person. They'll say, maybe I can hear my neighbors talking about me or plotting against me through my walls. And then we've got thought insertion, where they think say someone or something is putting thoughts into their head. Broadcasting, where they think people can hear what they're thinking. Or withdrawal, they think someone or something is taking thoughts out of their head. So there are a lot of similar terms here that I just wanted to clear up. So we've kind of talked a little bit about a psychotic episode. Now, something I didn't mention was for schizophrenia, you need 6 months worth of symptoms. So in your first symptom, you probably say someone has had a psychotic episode. Then schizophreniform is just if they're under the 6 months that you need for diagnosis. And then we're on to our kind of different other things. So you've got this schizoaffective disorder. All this means is they have some features of schizophrenia, some features of a mood disorder like depression. They don't do quite enough to be able for someone to put a pin and say this person has either of those two. So they just get given this schizoaffective disorder if they've got a bit of both. And then you've got your personality disorders that have schiz in them. So your schizoid, they have basically all the negative symptoms. So they're socially withdrawn, they'll be blunt, cold, very cold, and not really interested in friends. And then schizotypal is almost a little bit like schizophrenia light. They'll be quite odd, believe in like the sixth sense and like magic and everything like that. But they have a lot better insight and grip on reality. So on to our next SBA. I think it's a little double header. So just while people are finishing off their SBA, I saw a question pop up about, do you need to have more than one first-ranked symptom to be diagnosed with schizophrenia, and you only need one. If you have one of those, it's enough for a diagnosis. We'll move on to the answers. So going through important serious side effects of antipsychotics that it's important to know how to treat. So there are two main ones. So our first one, we have our acute dystonic reaction. Here it's an oligogeric crisis. This usually happens more in the young. I think there's a female prevalence as well. So procyclidine is a good bet in any extrapyramidal side effect, and you do an IM in any acute dystonic reaction. And this is neuroleptic malignant syndrome. So it's usually within the first couple of days of starting an antipsychotic. You'll get a triad of fever, muscle rigidity, and confusion. And this is treated with dantrolene, which is a muscle relaxant used in specific cases, which is this, I think, MDMA overdose and malignant hypothermia, which is actually kind of related to this as well. So these are probably the drugs you need to know some of the most about. So with the typicals, there's a long list of side effects. So I think it's important to try to group them. So I put them into your extrapyramidal ones, and then how to treat any of those side effects are put next to it. Then all antipsychotics have an increased risk of VTE. Then you've got your ones to do with your weight and glucose. Seizure and QTC are kind of put as like adverse side effects in your antimuscarinic ones. And QTC, so the QT interval antipsychotics prolong it, is very important. It's something that psychiatrists stress a lot. And one last thing is you can give an IM depot of any antipsychotics if you're really worried about whether they'll actually take it or not, if they've got really poor adherence. On to our next one. So they absolutely love clozapine monitoring at UCL. It's a bit of an annoying thing, but it's just something you have to learn. So it's clozapine's an atypical antipsychotic, which should only use last line due to its risk of agranulocytosis. So what you need to do is you need to measure the FBC once a week for 18 weeks. Then you do it every 2 weeks up to a year, and then you do it every month after that. So antipsychotics are dirty drugs with a lot of side effects. Therefore, there's lots of stuff that you need to monitor. So clozapine and FBC monitoring is the most important. I've listed all the monitoring that NICE mentioned, but I think the other important one is initial weight monitoring. This is especially for atypical antipsychotics, as the weight gain can be a real issue. So as I mentioned, clozapine is important to be acquainted with. It's a very effective atypical antipsychotic, but it's used third line, and you need to have tried 2 other antipsychotic drugs before you can give it to someone. Clozapine counselling is a potential OSCE station. Again, any OSCE stuff for peds or psych they've been doing from 5th year are released in separate documents. These are mostly SBA focused. So with clozapine, adherence is really important. Basically needs to be really painstakingly titrated up because of its side effects. And if they miss more than 48 hours of doses, you need to start again with that, which is a real bother. We've got another double SBA here. So this is a presentation and distinction that UCL have tested time and time again. It's slightly cheeky for me since I'm introducing bipolar as a topic, but it's not the answer here. So the key here is how quickly their mood changes. So the pattern in bipolar is classically normal-ish mood at baseline, and then their mood disorder, so either their mania or their depression, will have a distinct start and a distinct end, and episodes will usually last a matter of weeks. So mood lability over this course, so then changing like their mood from day to day or over the course of the day, that will not be bipolar in an SBA. So the short-term mood lability is more indicative of emotionally unstable personality disorder. So the impulsivity is seen in both EUPD and bipolar, with the self-harm being very typical. So what she's having with the out-of-body experience are episodes of dissociation, again, which are typical in EUPD. And they can get hallucinations when in times of extreme distress, with them most commonly being associated with a history of childhood trauma, and it's usually of a verbally abusive or distressing nature. There's a fairly classic manic presentation here with severe functional impairment as he's not gone to work for 2 weeks. He's got delusions of grandeur and they get paranoid if you don't believe those. While being kind of like one with the environment, basically like being on stimulants as textbook, what is actually seen quite a lot is them getting really irritable and also invading their personal space, invading your personal space. So you need 2 distinct episodes of mood disorder for diagnosis of bipolar. So one of these has to be manic. So both of them can be manic, but if you have both of them depressive, then that's just unipolar depression. So you need 2 distinct mood episodes to get a diagnosis. So I just want to go through the differentiation between mania and hypermania. So there's no marked functional impairment in hypermania, and there's no psychotic symptoms in hypermania as well. So someone who's hypomanic, they might be sleeping less, more energetic, more talkative. They're still able to go to work and just kind of cope with their life. Whereas someone who's manic will have a complete interruption, everything that they're doing from their symptoms, and they might also get psychotic symptoms. So with mania, there's a stepwise approach. The first thing you've got to ask is, are they already on lithium or valproate, i.e. long-term bipolar management? If they're not, then you go up this kind of ladder, starting with one of these 4 antipsychotics. Then you try another one of those. If that still wasn't working, you'd add lithium on to that second antipsychotic you tried. And if that still wasn't working, you'd add on valproate. And finally, you'd go for ECT if just nothing's working. So be a bit careful with antidepressants in treating depressive episodes in bipolar, as it can precipitate mania. And if they are on an antidepressant in the question, the first thing to do if they become manic is to stop that antidepressant. So if you are going to give an SSRI, you would make sure you give an antipsychotic with it to balance it out. So in bipolar depression, you can give fluoxetine and olanzapine, or you can just give quetiapine on its own. Again, it's something where management depends whether you're already on long-term lithium or valproate. So if you are, what you do is you check lithium levels, check their lithium is at therapeutic level, or if they're on valproate, you check that they're at the max dose. And then if they are, then you just do the top 2 steps, i.e. adding in the fluoxetine and olanzapine. Then now just looking at long-term management, it's pretty much lithium and valproate are the mainstays. And we'll go on to those in a second after this SBA. So here you've got a very typical history of lithium toxicity. So drugs affecting its excretion affect the proximal convoluted tubule. So this is why you can get it with thiazides, you can get it with ACE inhibitors and NSAIDs, because they all affect this part of the kidney, which then reduce the excretion of lithium, but you won't get it with loop diuretics like furosemide. So lithium is important to know about for both SBA and OSCE. I don't think you need to know every side effect, but I think tremor, nephrogenic diabetes insipidus, the hypothyroidism, and any arrhythmias are important to know about. So I think the most bait thing in an SBA about the change to toxicity is change from the fine to the coarse tremor. So what does that actually mean? So it's actually just about the amplitude, or how much they're actually shaking. Like a fine tremor is kind of fairly hard to notice unless you kind of make them put their hands out and watch them, whereas a coarse tremor will affect them doing anything. It's their hands shaking that much. So if you're getting renal failure or neurological symptoms of lithium toxicity, it's probably this time you want to start thinking about dialysis. So about the monitoring of lithium, I've put in pink the key facts, just about when you take it and how often you need to do it. And then you need to do some regular monitoring due to its side effects. According to a question on mock, use and ease is apparently the most important one to monitor due to how common diabetes insipidus is. So the next SBA. So it's important to quantify the severity of depression, and the easiest way is looking at the level of functional impairment, of which this patient doesn't seem to really have any. He's just been promoted in his job. He seems to be doing well. So technically we're looking at sub-threshold depression here, as they've got less than 5 symptoms of depression. I've highlighted the ones they do have in yellow, the ones they don't have in red. And he's got no functional impairment. So what you're looking at is self-help or low-intensity psychological intervention, stuff like computerized or group CBT. So I think it is important to know your 5 DSM kind of symptoms of depression. I think you get a pretty good idea of it, kind of doing stuff like GP or psych, looking at any stuff like the PHQ-9. But I think it is a good thing to have aware of what all of them are. And as I said before, the easiest way to categorize or rank depression is basically by looking at the level of functional impairment, which you'll just get an idea of from the STEM. So we've got a nice stepwise kind of categorization and management. So your first step is your initial assessment of anyone that walks through the door. And then you kind of start to assess them and categorize them. So if you've got sub-threshold or mild, as we said before, you're looking at self-help or your computerized CBT first. And then if that wasn't working, then you'd go on to your individual CBT. And if that still wasn't working, is when you'd start to think about your SSRI. But if you think they have kind of moderate severe depression, you go straight to step 3, probably hitting them with both an SSRI and CBT. Usually if they haven't had anything before and you've got CBT and SSRI as different options, I'd err on the side of going for CBT first, as UCL likes a kind of nice holistic talking therapies before whacking people on medication. On to our next SBA. So I think it's important to know your follow-up when starting SSRIs. Basically, this is because they can initially cause an increase in suicidal ideation. So you're looking at 1 week in those under 30. This is because I think it's been proven that this group are more affected by this, or if they're high risk for suicide, which is stuff like your severe depression or previous deliberate self-harm. So I've listed 5 side effects of SSRIs I think you should need to know. There are obviously quite a lot of them. It's important to tell patients not to stop taking them suddenly, because basically effectively this starts starving their brain of serotonin and they get these discontinuation symptoms, which are just kind of the opposite of what you want to be happening from your SSRI. And on the right is the steps you do with the medication. So your first SSRI, then you try a different one, and then you kind of get into your treatment-resistant depression and starting your kind of more weirder drugs. And it's important to kind of tell them they need to continue taking them even after they still start to feel better, which is 6 months if it's their first episode, or if they've had recurrent depression, you probably want them to keep on taking it for up to 2 years afterwards. I think this might be a good point for a 2-minute break if people want to go to the toilet or get some water, so we'll recommence in 2 to 3 minutes. Right, we can get back underway. So on to the next SBA, the next topic. So one thing that is key here for the correct answer is basically the time since the incident. So you can't diagnose PTSD before 1 month of the traumatic incident. You must have had symptoms for 1 month, and it must be over 1 month after the incident for a diagnosis of PTSD. So therefore, what we're looking at is the acute stress reaction, which is basically all the same symptoms but happening within a month of the incident. So we're on to our anxiety and stress conditions. I won't spend as long on these as they're not super important for SBAs. So we've got our generalized anxiety disorder, which is widespread. So basically worrying about a lot of different things. It must be difficult to control and present for over 6 months to be able to diagnose it. We've got another one of our classic nice stepwise managements, where you go from the usual suspects, so your self-help to your CBT to your SSRI. It's all fairly standard. So you've got your panic disorders. So you can get panic attacks in a range of anxiety and stress conditions. But for SBA purposes, if they're getting panic attacks in kind of a wide range of situations and they've got normal mood and anxiety between, then this is panic disorder. Whereas, say, if you had background anxiety and were getting panic attacks, you might be thinking more generalized anxiety disorder. Or if you're getting panic attacks in a certain scenario, you're looking at a phobia. Obviously, there's a lot of overlap with this in real life, but for kind of SBA land, the definition is about the mood in between. And if they've got relatively normal moods and anxiety levels in between, and they're getting these kind of relatively random panic attacks, that's what you're looking at, panic disorder. So when someone is having a panic attack, you get the fairly characteristic tingling in the hands, feet, and mouth. That's how you can differentiate from stuff like asthma and other respiratory syndromes. So why you get this actually is because you're getting the respiratory alkalosis because you're breathing off all your CO2. That causes the blood pH to raise, which then basically affects the calcium binding in your blood. So you actually get a hypocalcemia, and that's why you're getting this tingling. So agoraphobia is kind of more nuanced than just doesn't leave the house that it kind of might be shown as in mass media. So often the biggest thing with it is the fear of feeling like you don't have an escape route to a safe place. It's strongly associated with panic disorder, basically because some people get panic attacks and this is such a shock to them that then they want to feel somewhere safe and like feel like they're protected. And this leads them kind of usually staying in their home as they feel safe. And they associate being outside, being with people in crowds or anything like that with a panic attack, and they don't want to have that again. So we've kind of gone through a bit about PTSD versus your acute stress reaction. So what I've listed there is just your cardinal features involved, which I think probably you're fairly aware of just from the everyday usage of it. So trauma-focused CBT is a pretty good first bet, unless a question clearly states that they prefer to try medication. Then you'd go for one of your antidepressants, and you'd only move on to risperidone, a antipsychotic, if they're really having crippling symptoms that they just can't get through life with. So OCD is a disorder that kind of public perception has been largely warped of what it actually is. Kind of what the generic term for OCD describes is actually obsessive compulsive personality disorder, which is kind of like the beta example is your librarian who stays late every night reorganizing the books because they have to have it a certain way. But she wants to do this and she enjoys it despite the fact that it's having a negative impact on her life. So if we actually go to obsessive compulsive disorder, it's where you have obsessions and compulsions. So obsessions are repetitive, unwanted, intrusive, distressing thoughts that kind of keep on invading their head over and over. And they feel like the only way that they can kind of alleviate the distress and anxiety that these are causing is to do a compulsion. So compulsions are usually done in a very kind of stereotyped, fixed, rigid way, and they can be associated with a normal thing. So you get some people who have like obsessions about kind of germs. They get intrusive thoughts that their hands are dirty and that's going to cause them to get an infection and they're going to get really unwell. And, you know, washing your hands isn't an unreasonable thing to do. But the thing about a compulsion is it will be clearly excessive for what they're trying to neutralize. So in this example, this would be, let's say, them washing their hands so much their hands will raw and red and completely over the normal bounds of hygiene. So on to our next SBA. And on to the next one. So, as I touched on briefly before, schizoid personality disorder can be thought of basically having the negative symptoms of schizophrenia. So, you get your social isolation, your blunted affect, lack of emotion, basically no interest in friends or sex. So, a lot of people would think this sounds like antisocial personality disorder, from the kind of common meaning of the word. But antisocial personality disorder is more about just a lack of regard for any rules or the feelings of others. They have no remorse for any of their actions. And this is a follow-on from childhood conduct disorder. Avoidant personality disorder is a bit of a strange one, but it's where people avoid people because they're so concerned about being liked and they're so sensitive to criticism. They have this self-imposed isolation because they're so sensitive of saying something wrong or doing something wrong, but actually they're kind of craving attention and for people to like them. Schizotypal, again, is more of the positive symptoms. So they kind of be odd, inappropriate affect, but like magical thinking, kind of sixth sense, stuff like that. But they have a much better grip of reality and insight than schizophrenia. So we've touched on EUPD before. This is the more kind of very traditional presentation of intense relationships that they struggle to hold down and self-harm. So DBT, or dialectical behavioral therapy, or mentalization, are best for personality disorders. These are more kind of therapies which go about imagining what other people might be thinking and feeling and working on your own response to them. And medication rarely works in any personality disorders. So I think the most you need to know about any of these personality disorders, I'd say, except EUPD, which I've kind of gone through a bit more heavily, is basically by having a caricature in your head. So I'll just kind of go through these briefly and like how I think of them. So Willy Wonka I have down for schizotypal. So he's got odd behavior, doesn't care for any friends. He's got inappropriate affect. He seems fairly nonchalant when there are children dying in his kind of his factory. And he's kind of got this kind of odd sense, magical thinking and everything like that. So Stalin was notoriously mistrusting, paranoid about others and putting in extreme lengths and executing comrades for very, very little. I guess we'll see if I'm an older generation or not, but I've got a few people from Skins. So we've got Cook from Skins for antisocial personality disorder, just extreme disregard for the rules, very feelings of others, run-ins with police, and just no remorse about anything like that. Then I've got Regina George from Mean Girls from Histrionic. Basically just needs to be the center of attention, strong emotions that don't really last, relationships being considered more intimate than they are. Again, I've got Effie from Skins for a good example of EUPD, which we've touched on. Trump shows all the cardinal signs of narcissistic personality disorder, so just think about him. So I have Michael Jackson for your avoidant. So he famously isolated himself on Neverland, but also had intense wanting to be liked and was very sensitive to any criticism. Then I put down comic book guy for your schizoid, and Buster from Arrested Development for your dependent personality disorder, where they're just completely dependent on others and can't do anything for themselves. So I've listed the kind of full features for all of them there, kind of probably to go through more in your own time as it's a bit dense, but I honestly think just having an idea of this kind of character in your head is enough for these sort of things, with the exception of EUPD, which is, I think, an important thing to know about, and particularly for an OSCE setting. We've kind of mainly covered it. There's different presentations and features it can have and treatment in the SBAs, but it really is an important topic that UCL likes to ask about. So on to the next topic. And one more. So this particular sign seems to come up a lot in SBAs. So proximal weakness to the point that you can't stand up from a chair without your arms is a very poor sign of just general function. I'll go through the full list of red flags in a second, but that blood pressure isn't quite there. I have friends who kind of sit at 90/60. It's not something you'd immediately summon someone to hospital for. Same with a heart rate of 50. Again, lots of athletes will have heart rates very low. The red flags are based on BMI, and it's 1 kilo a week of weight loss. So refeeding syndrome is a potentially fatal complication when you do get someone who's lost a lot of weight, who is then refed. So I've put the big 3 risk factors in the stem. So over 15% weight loss over 3 months, little calorific intake for over 10 days, and a BMI of under 16. So with these people, you'd look to initially refeed about 10 calories per kilo per day, upping it by about 200 calories per day. So anorexia nervosa has the highest mortality of any psych condition by a long way. It's about 5 times actually. It's defined by extreme calorific restriction driven by kind of a warped self-image and a pathological fear of fatness. So it can cause a very wide range of features. You can write a list 2 pages long, but I think the most important ones for exams I've listed in the bottom left, as we've kind of gone through the red flags a little bit. So treatment for eating disorders, it depends whether they're over 18 or under. So for your children, your adolescents, it'd be a mainly family therapy-centered approach, and there's really good evidence for this. In your adults, you just go for CBT, but there's lots of different psychological therapies you can do, none of which have particularly great evidence either way. Then on to bulimia, which has a binging and restriction as the key aspects. So restricting can be done in a range of ways. It can be your classic vomiting, but you can do it with laxatives, diuretics, or not taking your insulin in diabetics. So a key thing is the self-evaluation of their own weight is warped. They think they're a lot bigger than they are, and their weight goal that they'll say is also well below what is normal or healthy. But usually they are not underweight to the degree that people with anorexia are. So postpartum mental health is kind of something that kind of crosses two domains a little bit. Postpartum depression can be treated in a very similar way to just your normal depression, kind of stratifying based on how severe it is. So baby blues is incredibly common and benign and almost kind of natural. It should subside quickly within the first 10 days to 2 weeks. And it's the only one that's not linked with kind of previous mental health conditions. So you need to recognize postpartum psychosis quickly, as untreated it has absolutely terrible outcomes for the baby and mother. So it will be a very sudden onset, usually within kind of a few days of birth, and a lot of their delusions and hallucinations are often centered around the baby, which is why it's so critical to recognize this quickly. And anyone you have a slight suspicion of this should be sent straight to a specialist unit for assessment, and they'd usually be separated from the baby due to the risk and given antipsychotic treatment. On to our final SBA. So sudden onset neurological deficit with kind of out any medical explanation is conversion disorder. So it's seen of times of stress. Normally that's why I put in kind of they're currently going through a divorce. And also a kind of a niche sign shown here is la belle indifference, excuse my French, which is basically when they have this kind of quite startling neurological deficit and they just don't really seem massively bothered by it. So somaticization is basically they'll come in repeatedly with a host of vague symptoms over the course of the years. So they'll have like tummy pain, fatigue, MSK is classic, back pain is a real big one. And they basically also might not accept any of your negative tests, which is a feature it shares with hypochondriacs. The difference is that in somaticization, they're presented with this kind of constellation of vague symptoms, and they won't be reassured by the negative test because they're like, oh, but doctor, my tummy still hurts. Whereas in hypochondriacs, they're just obsessed that they have this serious underlying condition, and they won't accept that there's nothing wrong with them. They're convinced that they do. So somaticization kind of disorders being slightly rebranded as medically unexplained symptoms. So with these people, it's kind of very important to ice them heavily and just kind of address their mental well-being, and also to do interventions more about their comorbid mental health conditions that you're probably suspecting is going on in the background. And finally, we just have your weird and obscure things that can happen. I think you probably don't need to know about these for finals, but I just thought they're kind of cool to include as very strange things that can happen. Right, thanks very much for sticking with me. If there are any questions, particularly around like some of the stuff that start with all the different terms and some of your schizophrenia and everything like that, I know it's a bit heavy. And I think we're just sorting the feedback form, but we can post it on the group as well. But be very appreciative just of any feedback and let me know if there's any questions you have or anything you want clarifying. Now, I'm happy to stick around for a bit. So with generalized anxiety disorder, you go through your self-help first, and then your CBT, and finally then you go for your SSRI. I think it's the same one where probably err on the side of going for your non-pharmacological treatment over going straight with drugs. So I'd probably back CBT more. Depends how severe it is, though. Yeah, so I think we're just sorting the feedback form. Hopefully it should be coming up, but we can post it on the group as well. I'd be very appreciative if you could fill that out for anything. Do they use the DSM? Oh, they would have the feedback form there for anyone who's kind of still around. So if you wouldn't mind doing feedback, would be very great. But as I said, we'll post it on the group as well. So do UCL tend to use the DSM criteria for depression, or they use the major minor system for diagnosing? I think more is the stuff. I think I've seen DSM one more than is the. I think the major minor one is more the ICD, isn't it? Or is it? Yeah, I think it's more ICD. I think it's good to have a little bit of both in your head. So like, I think knowing the fatigue, anhedonia, and depressed mood are your kind of your core symptoms is useful to know. But I think you want to know your 9 DSM ones as well. I think it's incredibly harsh if they ask anything that's like banking on ICD versus DSM really. How much stuff do we need to know about the different types of CBT? None. Really none. It's not your job at all. That's a psychotherapist's job. As I said, you've got your CBT in general. There can maybe be like one for like kind of your one-on-one CBT versus your group or like individual, as in a low intensity versus high intensity. But I think that's pretty harsh. Usually they'll just put CBT. And in terms of like your how you do CBT, you don't need to know it. But again, you do need to know that, say, in personality disorder, you do DBT. Like explaining CBT to patients in OSCE. Again, I think asking you to explain CBT in detail would be pretty pointless because it's not something you do. Again, most of your banker OSCE station for psych are you're explaining schizophrenia or your bipolar. It's doing a suicide risk assessment. Again, for us, they had a history that was a history basically trying to go between two diagnoses. I think explaining the ins and outs of CBT and OSCE is unlikely due to the fact it's not really even done by doctors. I think maybe just having a slight understanding of what CBT involves, like being able to say like, oh, you in CBT, you're going to be working on the ways you think about things and your like mental processing. But I think much more than understanding what's involved isn't necessary. Do we need to know how to taper, switch between antidepressants? I mean, it's something that I had in like the deep dark recesses of my notes. Was the stuff about like fluoxetine having a longer half-life, so taking longer to clear. I think it's something to not get really het up about, just to know that like fluoxetine has a longer half-life, but it's something that I kind of had somewhere, but I didn't really focus on too much. Yeah, I wouldn't really stress about it. Sorry, just trying to see it. Can you mention a few examples of how disorders of thought form feature in psych conditions? So we can see if we can go back to the slides right at the start. So most of the thought disorders do come up in schizophrenia. So poverty of speech and ideas and thought blocking are what's called negative thought disorders. As in they are, something's missing basically, so their ideas or their thoughts are missing. Then these other ones, circumstantial and tangentiality. Again, you can see in mania as well as schizophrenia, but you can see in both. Perseveration, again, I've seen schizophrenia, but you can also see it in a few other things. It's not specific. Flight of ideas is your typical mania. And then your derailment, might move, and clanging, as I said, your loosening of associations ones. And those are probably more seen in schizophrenia. What makes night's move more severe than derailment? This was something I looked into, and I was not entirely sure. Like, they seem pretty similar. Like, I think derailment is more like they'll just be thinking about something. They'll kind of, it's like a worse form of tangents, basically. I think it's like tangents, but maybe with much looser links. Whereas night's move is just completely no logical link. They're just going from one thing to the other with nothing really to link it. But it's something I looked into, and there wasn't a clear differentiation. Slight postpartum depression occurs within 4 weeks post-delivery. Yeah, so I think I saw a definition where it said you had to have symptoms come on within 4 weeks, but that it could last up to a year. That's something, I think that was from Best Practice BMJ that said that. I think it's about how like it can last up to and beyond a year, but again, I saw a differentiation saying it had to come within 4 weeks, but I'm prepared to be corrected on that. You mostly see it come on fairly soon after delivery, and then it can last for a variable amount of time. Like a last call for any questions.
I really enjoyed the session, Ollie.
Thank you, Ed. I'll stop the recording.